So today's webinar, we have Scott Macpherson and Dan Warrender from our School of Nursing, Midwifery and Paramedic Practice. And they're going to be discussing mental health in the workplace, how to understand and how to engage with people who might be experiencing mental health issues. This is a really important subject, which I think affects the majority of us in one way or another. And I'm pleased to see it's being discussed so much nowadays and also promoted. And so I'm very much looking forward to hearing from Scott and Dan and their views and advice on this area. So I'll now pass over to Scott and Dan. Thank you very much.
Hello, everyone. You'll notice that because I was in charge of the slides, I put my name first. So it's Dan Warrender and Scott Macpherson from this point on. But that's us. We're lecturers in mental health nursing at Robert Gordon University. And that's our contact details there if anybody wants to kind of get in touch following this webinar. I guess what we're going to cover today, I'll just speak just now, Scott, and then we'll get into it in a minute. But something that I think is quite tough for us a lot of the time is capturing mental health. When we're asked to do anything about, you know what I mean, mental health, how do you sort of capture the key points in a short kind of period of time? And this is essentially what we've come up with today in terms of us having a conversation and covering some of the stuff that we think is quite important. So it's complicated, it's everyone's business, and all useful responses start with empathy. Do you want to say anything before we get going, Scott?
No, I think that covers it. I guess we just should introduce ourselves a wee bit.
Like you go first, because I'm bad at introducing myself, because I want to give people everything, first pet's name and all that stuff.
So controlling, is he? Like, his name goes first, but he won't go first in introducing himself. So I want to see how
much information you're going to give first.
You know me, like I'm always pretty brief with it. Mine goes much smaller than yours. So. I'm Scott Macpherson. I've been a lecturer in School of Nursing for about 8 years now, I think. My background before that was as a mental health nurse for 25 years now, I think. Also studied psychology, and I am a CBT therapist, a Cognitive Behavioural Therapist. And most of my working background was in the field of substance use before and into the uni as well. Okay, that's me.
Okay, so I'm Dan Warrender, lecturer in mental health nursing as well. I've worked with Scott for about 7 years, so just a year less than you at RGU. My working background was in acute mental health. Before that, I worked in kind of learning difficulties services. A lot of my interests around kind of borderline personality disorder, trauma-informed care, that kind of stuff. But I think I'm interested in just everything about mental health in general. And I'm a mentalization based therapist and still practice that with NHS as well. So I guess we can kind of lead into, it's complicated, and I can kind of stop sharing this screen just for a minute and we can have a conversation. So like whenever anybody asks about, you know, I mean, mental health, what's it all about? You know, I mean, what causes kind of mental health issues? I think it's a hugely difficult question to answer because there's so much kind of influences on our experiences. You know what I mean? We're all unique individuals for a start, but then we all have unique experiences. I mean, I'm wondering about one of the first things to maybe mention is that there's a kind of an established or an understood biopsychosocial model in that George Engel, this guy in the 1970s, kind of recognized that the medical model of understanding mental health, mental distress, was largely kind of medicalized. So it was understood as kind of brain diseases, you know what I mean, things that were wrong with genetics and biology rather than anything else. And really said that we need to emphasize the psychosocial kind of stuff as well. So the psychological being the meanings that people give to the world around them, and social, the stuff that happens to people as well.
I think about the title of this. Well, our title was kind of the basics, but we're talking. Sarah was saying at the start, you know, we're talking about kind of mental health in the workplace. And I know that both from speaking to people in the past, even within RGU, a lot of people are scared by the idea of the, I know we're going to kind of talk about the phrase mental health and what it means and what we understand by it and stuff, but people hear that someone has mental health issues or just see somebody kind of acting in a slightly different way. There's often a lot of fear around that, a lot of worry about kind of how that person's going to be, if we're going to break them, if we're, how they'll receive what we do, and then a lot of avoidance of just being a human with them, just being ourselves, speaking to them as we would speak to them before we knew that they were experiencing issues. And I think that there's a huge amount of complication comes in there, isn't there? That we complicate things for ourselves by thinking, oh, wait a minute, something really different about this person that requires something different from me.
Yeah, that's brilliant, Scott. You've just kind of said some of the stuff we're going to say later on, but said it now. That's magic. Thanks for that.
I've introduced it as just like a soup song of it. I haven't done it all.
I mean, I think one of the most important things that we probably do as kind of lecturers in mental health is just to sort of own, I guess, the limitations of our understanding of mental health issues. I mean, I think something that we're always keen to emphasize is that sort of beware of experts to a degree. I don't mean beware of us, but I think what we quickly try and do is try and sort of play down our expertise to a degree. I mean, I think we've got certainly a degree of understanding about some influences on mental health, but in terms of understanding individual experiences, it is so kind of complicated, and anyone that is kind of framing themselves as having the answers, the absolute truths, is worthy of a little bit of suspicion, because it is so complicated. And certainly what we have to be mindful of is any kind of reductionism in understanding. I mean, there's always a ton of things that influence what's going on for people. I mean, we talked about the biopsychosocial stuff. I mean, I think it's maybe worth kind of mentioning sort of Occam's razor, which is the inference to the simplest explanation. And with the rise of understandings of adverse childhood experiences, trauma-informed care, that kind of stuff, if you can look at someone's life and see there's been a lot of adversity, a lot of kind of difficulties that they've experienced through things that have happened to them, then that is probably likely contributing to the distress that they're experiencing. So at that point, we maybe don't need to look for mysterious kind of biological, genetic kind of influences. It might actually make sense given their kind of context.
I think Occam's razor is useful when we're good at taking other perspectives or good at being empathic, but actually could be unhelpful, kind of thinking, well, Dan's talked a lot already. Simplest possible explanation is that he's an attention seeker. He just loves attention, and actually maybe that's not. I haven't tried to take his perspective. Maybe if I try and take his perspective, maybe he's a bit nervous. Maybe he's got loads to say and he's nervous about the amount of time that we've got. I think we need to get through all of this, or maybe he's just trying to stop me talking because he's nervous about what I might say. Or that I might give away some of the other stuff that I'm
always keeping an eye on time when I'm with you because you don't. So I know that I need to. Yeah. I mean, I was just thinking about the huge debates around causation of kind of mental health issues and how they're understood. Even amongst clever people, people that are doctors, professors on kind of almost sort of two sides, I mean, you've maybe got the people that might identify as kind of critical or anti-psychiatry, and then people that sort of say that the medical model or the understanding of mental health is based in kind of stuff that's happening in the brain. People that can all sort of to a degree justify their points of view, but in absolute kind of disagreement. And you go onto social media and Twitter and see these arguments are raging. You know what I mean? It's a really, really kind of controversial area. And I mean, maybe it sort of links to probably what we'll talk about later on. But when it's really, really complicated, then the best way of understanding it is to ask a person, you know what I mean? What is their experience? What is their kind of understanding of their own difficulties? I think
I remember hearing, like, a lot of years ago, the phrase "beware of therapist wisdom" or intuition. You know, when somebody's like, I know what's happened to you. I can tell, and you haven't told them what's happened to you, or you haven't told them your experience, and they profess to know what it is that's going on for you. Really, you know, like, can't kind of overstate that enough. Be really wary of anyone who's kind of offering you those sort of responses, but without hearing your story, without trying to listen to your experiences, because best case, they're generalizing and they might get some of it right. Worst case, they'll get it completely wrong, and you'll feel unheard, less valid, not cared for.
Yeah. Maybe that's the best way of kind of going back to Occam's razor, because I'm still, you know, I mean, I'm disgruntled that you kind of just chuck that away. But like, I think if you're,
I wasn't chucking it away.
no, I know what you mean. But like, if we look at Occam's razor and we're doing that thinking without involving the person, I think it's very useful. You know, I mean, if we kind of take that person's perspective, you know, I mean, along with some of our understanding, and then we can go with the simplest explanation based on what they're telling us. You know, I mean, it's like that kind of nothing about me without me kind of phrase sort of comes to mind.
So I think pretty much exactly what I said about Occam's razor.
No, I said it better though. Yeah, I don't know. Do we need to say anything else about the fact that it's really complicated?
I guess it just made me think of that kind of in the workplace, you know, the fear that people have. And I know that there are a variety of kind of initiatives and courses that people have developed, and a lot of those are based around the biological or the medical model.
Yeah.
And you know, it's about kind of, you know, if someone has this disorder, if someone has this label, then this is how you respond. This is what you should do, and that can be useful, because it can help people get a bit of understanding and kind of demystify some of those labels. But what's the shame is that then it ignores the other mental distress that exists without the labels. Or, you know, if I don't know, I don't want to give too. I'm nervous that I'm giving too much away too early as well. But we often talk about that kind of people needing, you know, the whole system, the whole mental health system that we have at the moment, the whole statutory system anyway, based around the medical model, and access to help requires the giving of a label or the receiving of a label, and the receiving of a diagnosis. And I know we always talk with students about kind of the lack of science around labels and around diagnoses. And I know you've got a great story about that, Dan, about how kind of diagnoses came into being in terms of the way we understand them now.
Yeah, I mean, that's like when we're saying it's complicated, like I think and it was certainly a revelation to me, because I remember qualifying as a mental health nurse and really thinking that these kind of diagnostic labels were really sound categories, you know what I mean, that people had this label and they definitely sort of fitted into this box. In the story that Scott's referring to, there's a guy, James Davies, who's written a book called Cracked, where he went in and interviewed people that created the DSM-3. So the DSM is the kind of American psychiatric diagnostic kind of manual. And in it, he interviewed people that sort of developed this DSM-3 in 1980. And that was the point where like mental health diagnosis kind of became a sort of checklist system. You know what I mean? Like we've got 9 of these symptoms. If you get 5 of these and over, then you've got that label. And he talks about how it's essentially done through votes rather than kind of hard science. And like, I think it has progressed on from this point, but at this point in 1980, you're talking about between 9 and 15 psychiatrists in a room, predominantly white men, deciding what is normal and what's not normal, essentially, you know what I mean? Deciding what's a disorder and deciding the thresholds for it as well. And it's quite an uncomfortable story, you know what I mean? The power that goes in that essentially they'll just kind of have a discussion, have a vote, and then move on to the next thing. And there's some descriptions of people that were in the room saying it was more akin to kind of people deciding what kind of takeaway they were going to order than a kind of scientific process. And even the power in it illustrated really quite well when one psychiatrist said, oh, you can't have that in there as diagnostic criteria because I do that. You know what I mean? So there's something about kind of diagnosing deviance or just stuff that's different to how you are, and there's a lot of power in that. And actually some of the hang-ups from that are still felt today in terms of the way that we kind of have that checklist system. And some of the diagnoses, you know what I mean, I think like borderline personality disorder, that first appeared in 1980 during that process. And I think like understanding how limited, you know what I mean, these kind of labels are in terms of being like accurate scientific descriptions of people's experiences is hugely, hugely important. And yeah, maybe we should have started with that, Scott.
I mean, we don't have to look too far back in history to see other things that were diagnosed, you know, conditions or things that were given labels that now we consider absolutely normal and ridiculous to give labels to. You know, homosexuality was considered a mental illness not all that long ago. Yeah. Absolutely crazy for us to think about that now.
1970s, wasn't it? So, you know what I mean, you're talking about 50 years ago.
I thought I was being good replying to people in the chat, but actually I sent it by private message to Sarah, one of the well, Sarah who did the introduction at the start, but I've sent it now. So hopefully I'll try and keep a better eye on what I'm doing with that. I'm happy to move on to our kind of it's everyone's business part now, Dan. Is that what you're doing?
Just a sec, but so
I've actually copied and pasted the wrong thing.
Just so I can use the slide that I spent a long time, 10 minutes doing before this. So it's everyone's business. I know this is your phrase, Scott. I'll let you own it.
I think like we when people use the term mental health, we often hear it. I guess I was going to use the word misused, but I'll change that. We often hear it used in a way that actually describes mental illness or mental ill health. And as a consequence, when sometimes when people use the royal we, when we hear mental health, the phrase, when that phrase is used, what we actually hear, what we actually understand is mental illness or mental ill health. And actually we think that's really unhelpful, and it's not the same with physical health. If we hear the phrase physical health, what springs to mind for me is a sense of good health, you know, physical health like running, exercise, eating healthily, that sort of stuff. Why is it completely flipped for mental health? And I think perhaps it's because of this fear and because of this idea that then people who have mental illness or mental ill health are different, and it's a separate group and it's nothing to do with us. And I know that like Dan and I created an initiative called Mental Health Movie Monthly, where we show a film kind of each month and talk about mental health. And the primary objective of that was just really to try and get this message home to people that actually it's everybody's business. Mental health belongs to everyone, and it exists on this kind of continuum of really poor, like real mental distress, really, really tough times, to being really mentally well.
Yeah, I mean, I think you're totally right about that image. You know what I mean? Like, I was just thinking physical health when you were talking about that. Yeah, I always think like Mr. Motivator or something like that. You know what I mean? Yellow lycra and working out and being all fit and healthy. But like, there's been critique that like anytime mental health appears in the news, it's that kind of head clutcher picture. So it's like somebody with their head in their hands like that. And that's not mental health. You know what I mean? Like, when you think about mental health, I mean, I guess the issue is that we don't have an image of that. I mean, how do you describe a positive state of kind of well-being? Just someone smiling or whatever? You know what I mean? It's people automatically go to that, and that's been some of the criticism of mental health services and the way we understand it, is that there's a fail focus. It's not a focus on being well, it's a focus on, right, okay, when everything goes wrong, you know what I mean, then we'll kind of intervene, we'll try and help at that point. And even thinking about like mental health services, they're not actually mental health services, they're mental health problem services. That's the way that they're kind of set up. They're set up to respond to problems rather than promote health. I mean, certainly we'd hope that promoting that kind of health would be part of it, but I think that the main kind of bread and butter of what these services do are often kind of responding to crises and when things have went wrong.
Mm-hmm. I think for a lot of years now, we've been in the horrible position of not having enough resource for mental health support in terms of the statutory stuff. So the NHS has been kind of on its knees for a long time, and we just don't have enough staff there to provide the sort of help that we ideally would. Which leads to a situation where some people end up really frustrated because they know that they're, as Jen saying in the chat there, what are your feelings on self-diagnosis? They know that they're struggling. They know that they're in distress. That times are tough, and they go to what they think is the service that can help them, and then they're told that you're not unwell enough to get the support from here. You're not unwell enough to get the support that you think you might need, and sometimes they get some support, but that might not be enough or might not feel enough, and sometimes maybe they don't get any support there, and they have to go back to GP. And sometimes GPs can provide really good support, and other times GPs can struggle with that. And GPs have got a really tough job, haven't they? Because they got 5 or 10 minute appointments to see people, and again, you know, it's a question of resource, because GPs are good people generally, and they want to do a good job. But in 5 minutes or 10 minutes, you're not going to be able to do very much that's particularly helpful for someone who's in mental distress. So sometimes then people get that biomedical model approach, and they'll just get a prescription. Mm-hmm. And that might be useful for some of the time, but most of the time, just some tablets is not going to be quite enough, and we probably need more. And well, my own background in CBT, often hear people telling me there's a long waiting list for CBT, or, you know, the GP said they would like to refer me for CBT, but would have to wait a year or 2 years or something to get it. And that's really sad to hear, isn't it? You wouldn't get that with a physical, or you would rarely get that with a physical health problem, you know, where a doctor or a health professional would be saying to you, well, I know you've got a broken arm, or I know you've got diabetes, maybe we'll be able to help you in a year with that. We might be able to get around to you in 2 years. It's unthinkable.
Yeah, I mean, just probably to emphasize that point of the limitations of that diagnostic system, you know what I mean, is that you are left with these kind of leftover or not sick enough kind of categories, you know what I mean? So if you meet sort of 4 criteria for a diagnosis, but you need that 5th one to get the diagnosis, that means that you can't access treatment. And it doesn't mean that these 4 symptoms or experiences that you're having aren't really serious. It's because we've got a binary way of understanding mental distress, and you know, I mean, you have to meet a certain threshold before we intervene. And what often happens in those kind of circumstances is that, you know, I mean, if 4 symptoms are going untreated, you know what I mean, then it will become worse. And then when it becomes worse, then we intervene, and then it becomes harder to kind of deal with because we've not sort of not been as proactive as we would like. I mean, but at the same time, you know, I mean, I'm empathetic with kind of mental health services, because I know what it's like, you know what I mean? There is a struggle for resources, you know what I mean? And sometimes it's not just about the amount of resource, but maybe the planning or the use of resources and stuff as well. If we intervene with more people earlier, we might make things kind of easier for us later.
Mm-hmm. It's that fishing upstream thing, isn't it?
Yeah. And I was just thinking another thing that, like, it's worth kind of talking about is the 1 in 4 statistic, which neither of us feel is particularly helpful. So the idea that kind of 1 in 4 people will experience mental ill health in a year, and like, for me, what that implies is that, like, while the 1 in 4, like, I get what it's trying to do, it's trying to say this is quite prevalent, you know what I mean? Mental health is like 1 in 4 of us, that's a lot of us, isn't it? But I think the message it sometimes sends is that, oh, like three quarters of us will be fine. And I think what that can lead to is a kind of complacency and a disconnection from that kind of wider issue. And there's I like a quote from Dr. Alec Grant that says, 1 in 4 is a quarter of the truth. And I think that's it. You know what I mean? We're human beings. And I think, like, we talked about adversity and how that can kind of contribute to mental ill health and just living in society, which can be tough at the best of times. But I was talking to students a couple of weeks ago just about existing, you know what I mean? Like looking up at the stars, looking up at the sky and going like, why do I exist and stuff like that. That's even enough, like, to cause you some level of discomfort and distress. So there's something about being human that makes us vulnerable to like mental distress, you know what I mean? Because we're self-aware and we've got consciousness, and our thoughts can go in a variety of different directions.
I think that the statistic lends itself to othering, doesn't it? You know, that, okay, so that 1 in 4 people are going to experience mental ill health or mental struggles, and I'm not one of them. You know, I'm okay. That's not for me, that statistic. And I think, again, like I think it's well-meaning, but unhelpful. Possibly, I see some possible agreement of that in the chat.
Mm-hmm. Yeah.
Okay, you want to shift on to?
Yeah, I was thinking because we'll probably spend the most time on that. So let me just there we go. So what we'll talk about briefly now is how all useful responses start with empathy. And I guess over the last few years since we've been working together, Scott, we've kind of been, every time we teach, we've been kind of sort of chipping away and kind of thinking, right, these are the most important things, you know what I mean, in terms of responding to mental distress. And we've done a variety of kind of talks and stuff around that. And empathy is always in there. And actually, like, even though we're talking about different kind of concepts and stuff, they all really focus around empathy. Like if you're really, really taking someone else's perspective and trying to understand their experience, that really is the root of kind of a useful response.
I think there's a nice wee Brené Brown video where she talks about Teresa Wiseman, who was a nursing scholar, talks about her breakdown of empathy. She said that there are kind of 4 attributes of empathy, and it's kind of, it's in no, I was going to say it's in no particular order. Some of it isn't, some of it isn't, and some of it isn't even, easy for me to say. Just to be able to see the world as other people see it, so kind of to take their perspective, to stay out of judgment, to try and understand, try and make sense of what the other person might be feeling, and then to communicate that understanding of the person's feelings to them. So I mean, so there's Dan. He's silently nodding. He's got his kind of straight mouth, and now he's laughing. So I can try and see the world as he's seeing it. Maybe he's looking at me thinking he looks really stupid with those headphones on. Maybe he's kind of sagely acknowledging what I'm saying because he believes in that as well. I know a little bit about Dan, and I use that experience of Dan to make some of my interpretations as well. So I know that he likes Wiseman stuff as well because we've taught together for a while. So okay, trying to see the world as Dan's seeing it. He's maybe agreeing with me. Maybe he thinks I look a bit daft. I'm going to stay out of judgment. Okay, I don't absolutely know that he thinks I'm looking a bit daft, so I'll try and put that to one side. Try and get an idea of what he's feeling. Maybe he's feeling agreement. Maybe he's feeling, I don't know, happy that we're talking about this stuff. Happy that we're on the same wavelength or something. And then I can ask him, so I can communicate that back to him. Dan, have I got that right? Are you feeling kind of reasonably happy that we're talking about this stuff, that we're on the same wavelength here? Or have I misunderstood?
I wasn't sure if you were genuinely asking that there. Felt rhetorical, like you were just giving examples. But like I think what ties all that stuff together is like it's just a curiosity. And I think, like, you know what I mean, when it's a throwback to what we said earlier about kind of beware of experts, you know what I mean, particularly of kind of therapist wisdom or any mental health professional that's saying, oh, what you need to do is this, or just try this, or like, I think this is your experience. Like that can be experienced as being really quite infuriating. And the most important thing is that people feel heard and feel kind of understood. I mean, like, I think resisting the writing reflex is something that we talk about quite a lot, because there is this tendency to kind of just want to dive in and give suggestions and try and fix it. And again, you know what I mean, I think, like, similarly, the 1 in 4 statistic, it comes from a good place. You know what I mean, you see someone in distress, you don't want them to be distressed. You want to help them through it. But often that can kind of be about us rather than about them, because we've got a real discomfort with a person being in distress, and we want to fix it so that, like, we feel a little bit better about it. But actually, like, if mental health problems were as easily solved as, like, throwing a few suggestions at it, then people wouldn't have mental health problems. If it was as easy as, like, oh, you're feeling a bit down, have you tried going for a walk? Well, like, you know what I mean, if it was as simple as that, you know what I mean, people probably wouldn't have the degree of distress that they do.
Yeah, I think you know, the most important thing for us as humans is to feel heard, to feel validated, to feel understood. If we don't have that, then we don't feel connected to other people. I know we talked about biological, psychological, and social aspects, but I guess we didn't touch on the spiritual. And that feeling connected to other people and to a bigger purpose and stuff. That sort of stuff is about our spiritual wellness. And I'm not a hippie. You can see I don't have long hippie hair as well. But that spiritual point about ourselves is absolutely essential to us feeling like we can go on, to feeling like life's worth living. If we feel disconnected from other people and groups and disconnected from a purpose in our life, then what is there to go on living for? And it's that being understood or feeling understood that sits right at the heart of that.
Yeah, I mean, I sometimes wonder if the spiritual, it kind of fits into the psychological of the biopsychosocial and stuff, but I think, like, it's right enough that we do differentiate spiritual, because it is slightly different. But I mean, the psychological focuses around meaning, you know what I mean? But I think we give meaning to, you know, I mean, our relationships, we give meaning to ourselves, but there is that kind of wider bit of, like, making sense of what it means for us to be alive. You know what I mean? What's our kind of purpose? And I think this could get very existential very quickly, but, you know what I mean, we're born into the world with no kind of rule book, you know what I mean, and no clear, like, this is what you need to do with your life. I think there's definitely a lot of influences around us in society that indicate, you know what I mean, that you should be doing this, but there's no real kind of answer in terms of the right way to kind of live a life. And that's actually a lot of pressure, you know what I mean, to figure out what's the right thing for me. You know what I mean? I think there's that distinction between there's no meaning of life, but there can be meaning in life, but that can only come from ourselves. You know what I mean? They can't kind of come from outside us.
Yeah, and when we get that sort of well-meaning advice, like some of the guys are saying in the chat about just get out in the sunshine, you feel better, or, you know, just do X, Y, or Z, and that'll help you. What happens if you've already tried those things and actually you still feel crap, or you're still in distress, or if you take that advice on and then you go and do those things and then you still feel in distress, then potentially you feel like a failure because you've been told that's a way out of this. Feels like another kick in the guts, another rejection. Maybe I've failed at this. Where do you go from that?
Yeah, I mean, I was just thinking there about, you know, I mean, epistemic injustice was something I definitely wanted to talk about as well, because I think particularly so we're talking about empathy and talking about connecting with someone else's experience and essentially hearing their truth and kind of and trying to understand that with them. There is something about, if a person has a mental health problem or a mental health diagnosis, that a lot of the time they're kind of discredited in terms of their own experience. And there's a really nice kind of saying that people are often seen as unreliable witnesses to their own experiences. They're seen that they, you know what I mean, they can't accurately give us an accurate understanding of their own experience because of the mental health problem or the mental health issue. And as a result, you know what I mean, people don't feel believed and they become further kind of disconnected from us. And that's certainly a failing in mental health care at times, you know what I mean, where we don't really get alongside people. Because if we're going to empathize with someone, and this is hugely important, we have to empathize with that person's experience of us. You know what I mean? So if we're in that helping role, whether it's a formal professional role or it's a kind of, I don't know, just a friendship or whatever, we have to understand what it's like to be helped by us in the environment that we're doing it, in the way that we're doing it. And that can be uncomfortable, actually, because if you're really going to empathize with someone, then you might discover some things about yourself that haven't been helpful. And that's an uncomfortable place to be, because I think we all like to think that we're smashing life, you know what I mean? We're doing everything brilliantly and perfectly. And we're fragile to that, you know what I mean? When we've not kind of met our own standards, or if we've been experienced as unhelpful by someone.
Mm-hmm. There can be a temptation to generalize, can't there, a bit? And the biomedical model lends itself to that perhaps as well, with a series of symptoms or that need to be ticked off in order to give a diagnosis. Once you've got the diagnosis, then you're really susceptible to that stereotyping and that generalization. But then it discounts, even though we hear the term person-centered care a lot, but then it can be quite difficult to look at ourselves. And I know that you and I have done that a number of times and continue to do that, to look at ourselves and say, wait a minute, was I really providing person-centered care there? Was I really trying to understand that person? Or did I get caught up in that generalization and that kind of stereotyping of a person or a group of people, and was that unhelpful? And it's uncomfortable, but it's a really useful thing to do, that reflection. Certainly that's something that we always encourage is reflection, and in professionals then doing that reflection with another professional in clinical supervision, for instance. It doesn't have to be clinical, of course, that's just in nursing and so on, but supervision of some kind of formal supervision.
Yeah, a space where you can reflect and you can learn from things as well, you know what I mean? Because we're humans, and particularly if we're helping, we're human beings helping other human beings. So like it's impossible to kind of get a clear step-by-step way of doing that without very quickly becoming either kind of diagnostic centered or kind of ritualistic. Every human being is completely unique. And we need to remember that not only are they unique, but we're unique as well. So there's so much kind of complex dynamics going on in those relationships that influence those interactions.
So I guess what we're saying is if, like, we're not big on offering advice, but if we're often asked for advice, aren't we? You know, when we're asked to do kind of columns or write things, and people always say, can you just give us your top tips, or can you just give us your advice, or whatever? We're always like, oh, wait a minute. But I guess some advice would be listen to people, listen to people's experiences, help people feel heard, and reflect and think about what you're doing. Look back on what you've done. Think about if there was anything that was unhelpful about it. Is there anything you could do differently?
Yeah, I mean, and I guess advice to individuals that might be experiencing mental health problems, you know what I mean, is kind of know yourself and recognize that you are the expert. You know what I mean? No professional or kind of top tips or whatever is going to ever give you more information than you've got inside yourself. I know certainly that, you know what I mean, sometimes we can't see the wood for the trees, you know what I mean, in our own experiences. Sometimes it's actually easier to kind of help someone else than it is ourselves. But the understandings and the answers that we need will be in there somewhere. And sometimes definitely, you know what I mean, it's useful to have somebody else with you to help you get there. But there's nothing additional that they're going to provide that's not going to be within you. And I think that's back to that kind of whole beware of experts thing. I think like top tips or general advice is useful generally, You know what I mean? As a, like, all right, I might try those things. I've not tried that before or whatever, but it's not useful as a Bible in terms of like, all right, if I do this, then I will feel better. Because you're a unique human being. You've got unique experiences, a unique story, and unique needs as well.
Yeah, that's a really good point. That, you know, our experience of care, ideally, that should be based on a collaboration between you as the receiver of care and the person providing the care. And as providers of care, then what we should be doing is trying to reduce the power imbalance as much as we can, and be kind of on a level and treating the person's experience as the most important thing there, the person's experience of themselves, and the person being an expert of their own experience. And we should be trying to help the person harness that, as well as maybe some of the stuff that we have to collaboratively work towards where the person wants to go.
Yeah. Just thought as well, you know, I mean, maybe you should have mentioned it earlier on, but I think like something else that's quite powerful about the diagnostic system is when you've got a label, just what that can do to how you feel about yourself as well, and what it does to that kind of self-efficacy. You know what I mean? That feeling that you can maybe move past things. You know what I mean? I think sometimes if you get a label, get a diagnosis, you might think, oh, I've got this thing, or I've got this label, I'm sick, I'm ill. And that's not to challenge the idea that you're kind of, you know, I mean, I'm not sort of saying that people aren't feeling genuine distress, you know what I mean? But I think the way we understand it is really, really important, because if you think you've got a disease or an illness, that can be really quite disempowering. You know what I mean? Think, I've got this thing and there's nothing I can do about it. Instead, thinking that you're having an experience is much more manageable. I'm thinking like a classic example is probably anxiety, because anxiety is such a common human experience. You know what I mean? There's a bit of anxiety that I'm feeling just now. Like I keep forgetting because I'm just talking to Scott and stuff, but then I forget that people are watching this and they're going to listen, they're going to remember what I said. You know what I mean? That makes me kind of a bit apprehensive. But there's a difference between me saying that I'm having an anxious experience and then somebody telling me that I've got an anxiety disorder. There's a huge difference in there. And I think that there is, like, particularly anxiety disorders, there's a discomfort I've got there in kind of pathologizing something that's a really normal human experience. Don't get me wrong, sometimes you could argue, you know what I mean, it has a huge impact on people's lives. But I think understanding it as an experience helps us kind of try and make sense of it rather than maybe medicate it or something like that.
Yeah, you know me, Dan. I'm always ready to play devil's advocate as well. I completely agree with you. I also know that sometimes people find receiving a diagnosis validating as well.
Yeah.
Sometimes people find that really useful, and I know that we've spoken to people for whom that's the case. You said that actually it's kind of quite the opposite of what we were just talking about for me, that I received this diagnosis and then suddenly I understood, you know, that my life made a bit more sense, and then I was able to kind of move past where I was stuck, and it was the receiving of that diagnosis that helped provide that understanding and that ability to move forward.
Yeah, I mean, it's that person-centered bit, isn't it? You know what I mean? If we're genuinely connecting with people and understanding their experience, we should be talking to people about diagnosis as well. You know what I mean? In terms of, do they find it kind of disempowering or kind of stigmatizing, or do they find it really helpful? Aye.
Mm-hmm.
Hi, Sarah. I see you've popped back in.
Hello. I don't want to stop the chat because I think it's been really interesting, but I know we've also got a few questions that have come in, so I wanted to give a bit of time for that. Is there anything that you want to cover before I go into the Q&A?
No, I think we're good.
Happy to take questions, yeah.
Perfect. Well, I just want to say I thought that was really interesting, and I know you said that you don't give advice, but I've certainly picked up some really helpful I don't want to say hints and tips, but just ways that I can engage with colleagues or friends or family members that I know are maybe, you know, struggling right now or have been struggling in the past. So I definitely have found that really helpful. And I think the engagement that we've had through the chat function as well, I think everyone's agreeing with things that you're saying and also sharing their own experiences, which has been really nice to see as well. So thank you both for such an insightful chat. And I know that you could talk for forever on this subject. And I'm sure that if anyone does, I know that Dan shared your contact details at the start, and I'm sure that you would be happy to have a conversation if anyone wants to follow up with anything. Yeah. So just going into some of the questions that have come in. So question from Liz Hewitson saying, if I don't have experience with someone with potential mental health, how long should I support someone before saying they should seek medical help? They have periods where they can be very down, not washing, curtains closed, and adverse to going outside. I'm trying to be supportive, but not sure if I'm pushing too hard.
Yeah, I mean, like, I guess it's tough to give sort of general advice to an individual case, you know, I mean, particularly when we don't know like a lot of the detail. But I mean, I think I'd maybe sort of pull it back to trying to be led by the person as far as possible. I think that there's often something that, like me and Scott emphasize, that's really important is when you're working with people with mental distress, is actually sharing your own experience as well. And that means that me sometimes seen as a mental health professional, expert stuff, you know, I mean, that I put in inverted commas. Sometimes I share with people when I'm feeling a bit out of my depth, I'm feeling overwhelmed, I'm not sure that I'm doing the right thing, and trying to have really transparent conversations. And like, I think the more you are honest, the more you'll get back from somebody about their genuine experience. Because I think there's often a lot about us really worrying about getting it wrong, and we don't necessarily get to that place of being truly honest. And I guess just another thing before I'll pass on to yourself, Scott, but like we do have to be mindful of our kind of limitations as well. You know what I mean? I think like that whole you can't pour from an empty cup kind of type thing, you know what I mean? In supporting people, it can be incredibly draining. It can be really hard. And we might have to be honest with ourselves and be honest with others that we've got a line. And that's not about saying, I don't want to help you. That's just saying that I'm at the limit where I can't help you without becoming kind of unwell myself. And I think we need to, the worst part of that would be, you know, I mean, you don't end up with two people that are unwell. Yeah.
Thanks for saying all the things.
That's all right. That's all right.
Nothing left very much for me there, but I think that transparency, that was what was going through my head, was just being transparent about your own mental state, you know, just saying, you know, this is how I'm feeling, this is what I'm seeing at the moment, this is why I'm worried. And yeah, so being led by the person, you know, what do you think we should do, you know, where do we see this going, you know, when do you think it would be reasonable to see when, you know, when would you cross that threshold that to seek help?
Sorry, Scott, we were losing you a wee bit there. You were going in and out.
There's probably a lot of rubbish that I was talking about. I was just saying about the transparency being really important, and you know, about kind of what you're seeing, what you're feeling, and sharing that with the person.
Yeah, thank you. Another question is asking whether you would talk about OCD and constant doubt and reassurance needs. No.
If we could talk a bit about that.
Yeah.
Okay. Yeah, I mean, I've worked a bit with people who have the diagnosis of obsessive compulsive disorder in the past, and currently as well, actually. But so just really going back to kind of what Dan was saying just a short time ago about labels and stuff being perhaps unhelpful. Certainly that's something that I've done in my work around people with that label is really normalizing that as an experience of being anxious, holding anxiety, and then trying to kind of understand, you know, that these what the beliefs that we hold about ourselves and the world and other people are, and how those help to create and maintain anxiety. And it's certainly the case with OCD, you know, like someone who has OCD about cleanliness, say, then they perhaps hold beliefs about contamination, about the world, about that other people don't wash their hands enough or aren't clean enough, or you know, all these sort of beliefs that we hold about the world and other people and ourselves. They can lead to to us then having increased anxiety. So anxiety is about an increased perception of the risk that's involved in something and a decreased perception of our own ability to cope with that thing, that threat. So when we understand that, then what we need to do is try and up our own belief about how able we are to cope with the threat, and reduce the belief perhaps about how dangerous the thing is, how risky the thing is. So how risky is it to get your hands dirty, dig in the garden, or to make a sandwich and then not wash your hands after, or something like that. Well, certainly in CBT, we can use we can do some cognitive work around that, some thinking and talking about stuff, and we also would then tend to do behavioural experiments. And with OCD, then we would do stuff called exposure and response prevention. So the experiments are essentially like doing the things that you're anxious about. So you do them and then you just stay with the discomfort, and you stay with it until you notice that actually the anxiety drops off. The worry is that it'll escalate, it'll just keep going up, and eventually, you'll not physically explode, but emotionally you would explode. But actually what happens is it reaches a peak and then it decreases, and then it can help the person to understand, okay, the more times they do that, then the curve gets shallower, and then the person understands, okay, I can cope with this, and that helps with decreasing the amount of risk that's felt and increasing the perception of how much they can cope with it. Sorry, Dan, now I've said all the things, but
aye. No, I was just thinking maybe something small I could add to that is that maybe probably a mentalizing approach is distinguishing when something's a kind of an opinion instead of a fact. And I know you do that in CBT as well, you know what I mean? You do that kind of like exploration of thoughts, and you know what I mean, how much evidence is there that this thought is reality? Because, and not to kind of diminish the impact of people's opinions or their perspectives that are causing them a lot of distress, but I think if you can do some work with people around, like, well, what's the evidence that this is going to happen? What's the evidence if, you know what I mean, you don't wash your hands 10 times a day, or like that's not actually that's a probably reasonable amount of time to wash your hands, isn't it? I'm going to come across like an unclean human being, but an excessive kind of amount of times. What is I've lost my train of thought because I was thinking about being judged there for not washing my hands.
But yeah, looking for the evidence, yeah, about that empiricism, yeah.
Yeah. So the distinction between facts and opinions, what is something that you're feeling that's really real and really distressing for you, but how does that correspond with the reality around you? You know what I mean? Where's the actual kind of evidence for it? That can be a really, really useful conversation. And it's not necessarily quick. You know what I mean? If people have got these really deep held beliefs, it's not as simple as like, oh, it doesn't correspond with reality, oh, I'm going to be better. If it's really deeply held, that's going to be tough, but that would be the approach. And a lot of the good approach to working with people is persistence, and you know what I mean, creating connections and keeping going over stuff again.
Okay, thank you both. I'm just going to try and get through a couple more questions because I know we're short on time, but any questions we don't ask, we can come back to the individuals afterwards. So question, working as a paramedic, sometimes we're called to people experiencing mental distress. How do you engage with patients who do not want to communicate or discuss what is going on regarding their experiences?
Yeah, I mean, we're going to sound like one-trick ponies here, but like I'm coming back to sort of transparency again, you know what I mean? Because there's, like, I think everything's communication, right? So even if somebody's not communicating with you verbally or telling you exactly what's going on for them, they're probably telling you something. And like, I'm imagining it's pure speculation because I don't know this individual circumstance, but there's something about somebody feeling scared, feeling unsafe, being worried about trusting other people. So there's something going on there. And often a lot of that distress comes when we're really uncertain about the world around us and about people around us as well. So I think I'd be inclined to try and get alongside them and just be transparent about what's going on for me. You know what I mean? So I've come along to this incident. I'm really wanting to help you, but like, I notice you're not communicating with me. So I'm worried about doing the wrong thing. You know what I mean? So, and like, just being really, really human and really open with that. And like, again, it's just sort of hoping that you'll get something, and there's a bit of kind of persistence, a bit of kind of initiative, trying different things if you can, you know what I mean? There's definitely an issue in that, like, we often, and probably what we're doing today is emphasizing talking to people, but sometimes when people have been traumatized, for example, if they're triggered, if they're kind of in that state of high arousal, you're actually not getting to the frontal cortex, you're not getting to that cognitive part of the brain. So just helping people feel safe in a variety of means can be really, really useful. I was thinking of, like, I don't know if paramedics have blankets, but even popping that over something, like even a gesture of helping someone feel safe might be really useful. Again, that might be experienced as threatening for someone as well. You know what I mean? There's no one right thing to do. But I think starting off with being transparent is always a really useful thing.
Totally agree. They do carry blankets, Jen's telling us. But I think also, you know, like doing a bit of that kind of healthy Columbo as well. Like, don't really know kind of what's going on. You know, I'm wondering if you're feeling a bit scared, or I'm wondering if you've had negative experiences of, you know, of help or people coming to your door professing to provide help in the past, or, you know, I'm wondering if, you know, if some of that's going on for you. I wonder if you know, I wonder if you've been here before and you've had a bad experience with me before, or, you know, any of that transparent stuff can be really useful.
Great, thank you both. I'm just going to go with one last question, and I'm going to pick up a question from Shona because it's been talked a wee bit about in the chat as well. She's saying, one issue common to us all is grief. What would be your advice on broaching the subject with someone who's returned to work following the death of someone close to them? So often we avoid these people for fear of further upsetting them or saying the wrong thing. Getting it right is tricky. It's probably quite a common issue that a lot of us would face through the workplace.
Yeah. It's something that we've experienced recently, Dan, as well. But
yeah.
I mean, again, I really at risk of sounding like one-trick ponies now, but I think, again, it's that transparency, you know, about saying to the person, maybe, you know what you're feeling, what you're thinking. Actually, I don't know the right thing to say, but, you know, maybe that comes from some of that Brené Brown stuff as well. You know, I don't even know what to say. You know, connecting with the feeling must be really tough, or you must be feeling really devastated at the moment. I'm just here for you. You know, I'm here to listen, or, you know, whatever your line is. If you're not really going to be there for them to listen to them, then obviously don't offer that. But if you are, and you can be, then just letting them know, just that you're there and you're willing to listen, willing to support them. But yeah, just I don't know. That would be my approach. Just kind of saying, and I know that's been useful for me. When I've experienced grief, when I've been going through that, is people just saying, you know what, I'm here. I'm here for you. I'm willing to listen. You know?
Yeah, I mean, it's one of them things that you can't fix. You can't, like, there's nothing you can do. Even practical advice, there's nothing that you can do in that circumstance. So just showing in some way that you care, and like showing a willingness to be available, like if you do want to talk about it and stuff like that as well. I think something that can be difficult in workplace environments is, you know, I mean, is there a lot of folk like together? Look, remember when we used to be able to do that? Like, but is there a lot of folk? Maybe that's not the right moment to kind of have that conversation. Maybe it's like catch a moment where it's just you and them. Like, I guess just thinking about how the other person is going to experience that coming from you, but not owning your own limitations and that you're not going to fix it, and just being available and saying, look, I care, and if you want, then, you know what I mean, we can talk, or we can do whatever you want.
Great advice. Thank you very, very much to both of you for a really, really interesting session. I'm just so sorry that the time has come to an end and I've not been able to ask all the questions, but we will get back to everyone who's asked any questions in the Q&A. And as I said before, if you want to pick up with Dan, you'll probably kill me for offering this, but if you want to pick up with
our
Dan,
bosses will.
So I'll leave it down to them. But and I see lots of people are saying they find it found it really interesting, and I certainly personally find it very helpful. So thank you both again. And thank you to everyone for joining us today. It's been great to see such a turnout, and also so much engagement through the chat, which is great. It's really difficult to do some of these webinars when you're not actually getting to see the people face to face and have that personal engagement. But I think we've probably done the best that we could do in these circumstances. So thank you all for your engagement. The recording of today's webinar will be available on the RGE Knowledge Bites for Business webpage next week. So in case you want to go back and listen to some of what Scott and Dan chatted about today. And our next webinar is taking place next Thursday, and very different from this one. It's looking at technology and what uses it if no one uses it. So really looking at how we can change our culture to have more early adopters of technology. And again, more information can be found on the RGE Knowledge Bites for Business pages. So thank you all.